Ladies and gentlemen, dear colleagues, it's my great pleasure to lecture on how to perform contrast-enhanced ultrasound, CEUS, tips and tricks. First of all, a short introduction into the fascinating world of contrast-enhanced ultrasound. It's all about bubbles. You can see air bubbles within the gallbladder. You can see microbubbles within the vessels. And it's a didactic video. We might later on discuss about what can be seen here. First of all, new equipments are highly sensitive. With some equipments, we have to use 1/10 of the vial. And here's an example. You can see a cystic lesion in the liver, some nodules and septae, and we are interested if that cyst is a typical cyst or if that cyst is a neoplasia. Injecting Sonoview, and we can depict within the nodules enhancement, and we clearly can show it's a cystic neoplasia, a cyst adenoma. No washout in the nodules. Also, after, let's say, 6 minutes, yeah, here in the pancreatic tail, we can see sustained enhancement, still a dosage of 0.6 ml in that respective patients. It's a typical accessory spleen. Sustained enhancement, stability is nicely displayed. Some systems have really contrast enhancement without contrast agents. So we have tissue harmonic imaging, physics, and some special effects and artifacts we have to take care. And it's exciting to learn about those artifacts. The secret of good contrast-enhanced ultrasound is a good B-mode image. As you can see here, the common bile duct, 3 to 4 millimeters. Within the bile duct, there's echogenic material, it's a stone, and we nicely depict in that patient with acute biliary pancreatitis. Secret of a good contrast-enhanced ultrasound image is the best B-mode available, nothing else. Also, knowledge of Doppler. You can depict the right adrenal gland, and good Doppler modus allows us to depict the vasa supraadrenalis. Here you can see in a video the supraadrenal artery, and this is really sensitive Doppler. High Doppler frequency, the adequate pulse repetition frequency, a low filter whenever possible, and only at the end the gain. All what I'm going to discuss with you is about a paper which is open access in Ultrasound International Open, and it's written, and I show some images out of it, and it is the air that I breathe. It's Sonoview, and we can do it right and we can do it wrong. So first of all, we should connect the saline or fluid to the adductor, and not the adductor primarily into the gas, because the gas could go away. Therefore, that's how we perform it. Tips to do it right is to do it as shown at this stage, to put in a larger cannula in the left antecubital region, the Sonoview autograd into the cannula, and the saline flush through the filter. Never Sonoview via the filter, because it might be distracted. And then it works like shown. And here you can see nicely the position. The nurse to the left side, antecubital, large cannula, well prepared. The examiner to the right. All availability to handle the transducer, and then give the injection in a team. Tips to avoid would be to have the nurse on the same side as the transducer. The cannula is small. It's in the region of the hand peripherally, and you have the sonoview through the filter. Never. And the saline autograd, this is really wronger it could be. Wronger it could not be. Then we have a 3-stop clock here. We have all on the same side is a mélange. It doesn't fit. Wrong is IV cannula on the examiner side. Better contralateral to have the space nicely organized. Wrong is hand peripherally. Go antecubital, which is closer to the heart, to get reproducible timelines. Wrong, at least useless, is an extension line. Why an extension line if you could do it direct? And the 3-way stopcock is not necessary. You can do it stable in the position as shown. Never give sonoview via the filter distally in a small cannula. You might destroy the gas bubbles and the results are not as good. Useless are extension line, 3-stop clock, and some use it. They may use it, but we never do. Criteria of good images in general after the process of sonoview injections and some tips and tricks on to do it right or wrong is that we have enough signal. And here is too low signal. We can't see the contrast. Yes, quite nice. We see the signal and the non-enhancing areas. And oversaturation means you have bright echoes which could not be brighter than bright. And we have oversaturation and no good enhancement resolution. The criteria of good images, there are many, but 2 criteria are most important. Those are to avoid bubble destruction in the near field. It might depend on the mechanical index or a focus which is too close to the near field. Or you have a too high signal to noise ratio and shadowing. So we have quite good signal here, but shadowing downward here. And bubble destruction and shadowing should be avoided. This is quite nice video with enhancement throughout the image. 15 centimeters, including the artifacts down here. That's a good penetration, good sensitivity. Homogeneous enhancement during the entire image, and we can nicely depict the sad diagnosis of metastasis over here. The circle of disaster. Contrast dosage leads to shadowing. We might increase the mechanical index to get better depth penetration, and we destroy even more microbubbles with the signal, and we have more shadowing. The circle of disaster. All what I have been telling right now has been published in the paper shown here, pitfalls and artifacts using contrast enhanced ultrasound. Let's talk first examination technique. Right now we have been discussing on how to improve the image. Now the contrast phases. We have a dual blood supply in the lung and the liver, mainly and importantly in the liver. And we have that injection into the antecubital vein whenever possible, in a large cannula whenever possible, to the pulmonary artery, into the lung, and then to the left heart, to the aorta, and back into the lungs via the bronchial arteries and to the liver arterial vessels, and later the portal venous face. Let's see how it looks like. The right heart, right atrium, right ventricle, myocardium, left ventricle, contrast comes into the right ventricle, now into the left ventricle and into the systemic circulation. This means also into the myocardium in such a patient with amyloidosis. So first right atrium, then right ventricle, left atrium, left ventricle, systemic circulation. So what happens with the contrast agent between the heart and the lung? So we have the right heart, we have the pulmonary artery, and later on systemic circulation and the bronchial, or here the vertebral arteries, enhancing at a later stage. And then the liver, arterial phase, and a little bit later the portal venous phase. So we can real-time imaging the different phases of the dual blood supply in the lung and the liver. The dual blood supply in the liver is most important. The arterial phase of the focal liver lesion in comparison to the hepatic artery, and the portal venous phase in the liver of a focal liver lesion in comparison to the portal vein branches and in comparison to the surrounding liver parenchyma. This is what we are doing. Arterial phase in comparison to the artery, portal venous phase in comparison to the portal vein and surrounding liver parenchyma. The take-home messages are: malignant lesions are hypoenhancing the portal venous phase and sinusoidal phase. They are liver-specific vessels because liver foreign tissue, malignant tissue, infiltrated tissue, does not show that liver-specific vascularity, and therefore there's wash-out hypoenhancement. And the hypoenhancement in comparison to the surrounding liver parenchyma can be judged according to the timing and degree. Here you can see the hepatic artery, HA, portal vein branch, portal vein, and here a focal liver lesion. The focal liver lesion is enhancing, hyper-enhancing in comparison to the surrounding liver parenchyma, but in the portal venous phase, there's no, before the portal venous phase, no enhancement in the portal vein. The portal vein is not yet enhancing. Right now, a few seconds later, 2 seconds later, portal vein is enhancing, and you can see the hypo-enhancement, the washout in the focal liver lesion. Between here and here, 2 or 3 seconds. That's amazing. That's different to computed tomography, magnetic resonance imaging with very different time schedule for arterial and portal venous and whatever late phase. Here you can see with the enhancement of the portal vein, there is washout, possibly in the focal liver lesion. A little later, so it's early and marked, I mentioned timing and degree, we have that early and marked, punched out, wash out of a malignant focal liver lesion. Nicely in comparison to the hepatic artery in the arterial phase and portal vein in the portal venous phase. We have that biological behavior of different lesions, and if you have an aggressive lesion which is round, voluminous, it is aggressive at its circumference, rim enhancement. There the neoangiogenesis, all that aggressive vessels are at the border of the focal liver lesion. A little later, wash out. hypoenhancement. It's a very aggressive lesion. You can see here the rim enhancement in the circumference, and the washout demonstrates the behavior of a malignant focal liver lesion. That's all about malignant or liver foreign tissue focal liver lesions. Now we go for benign focal liver lesions. They show, because they contain portal vein branches and sinusoids, liver-specific vascularity, a sustained enhancement or hyperenhancement in the portal venous and late phases. And they characterizes most benign, but not all, solid focal liver lesion, except hepatocellular adenoma. They can be further characterized by specific vascularity enhancement pattern. The peripheral nodular contrast enhancement, you can nicely see here. Peripheral nodular contrast enhancement is a typical feature of hemangioma and a centripetal fill-in. Be aware that this peripheral nodules stay hyper-enhancing. If you have that peripheral nodules, as seen here, and they show washout, then it might be a malignant focal liver lesion mimicking some aspects of hemangioma. This is a typical aspect of hemangioendothelioma, a semi-malignant tumor of the liver. So benign lesions stay hyper-enhancing the peripheral nodule throughout all phases. Whereas when you can see a washout in those nodules, be aware it might be a differential diagnosis, a pitfall. All has been written about the contrast-enhanced ultrasound features of hemangioendothelioma in this paper published in the World Journal of Gastroenterology. Focal nodular hyperplasia. The typical feature is central arterial blood supply. It might be central, it might be eccentric, it might be multilocular. So here you can see predominant central vascular blood supply, but we can see also peripherally and eccentric some vascular blood supply. And we have a fourth dimension, which is a color. And the color, early yellow, later green, right now blue, gives us a fourth dimension that we know it's a centrally enhancing liver lesion. Malignant ones would be aggressive at the border, destroying the neighborhood. But here we can see it's a typical benign focal liver lesion, with highly architectural vascularity and a typical focal nodular hyperplasia, showing the timeline of enhancement. Sustained enhancement of such a lesion, here you can see next to the heart, sustained hyperenhancement in the late phases is also a typical sign of focal nodular hyperplasia in 96%. You might read in the papers that it has been published that FNH shows hyperenhancement only in 50% of patients. Then you have perhaps data where there has been bubble destruction in the highly dense vascularized focal nodular hyperplasia, and they have wrong results. But regularly, FNH contains atypical but portal vein branches, and they are hyper-enhancing in all phases, also in the portal venous and late phase. The pathophysiology of focal fatty sparing is that it might show mesh-like features, but typically they have a central artery, a predominant arterial perfusion, less portal vein perfusion, less fat, less insulin, and therefore hypoechoic because they are less fat containing in comparison to the surrounding steatosis or fatty liver. And we can not only diagnose such lesion for sure as a focal fatty sparing, we can also understand the pathophysiological process behind. That's amazing. Real-time imaging, high detail resolution. That's all we are talking about. Beyond blood vessels, you can see the esophagus in about almost all people for, let's say, 4 centimeters. And we can swallow and detect during swallowing the air and the esophagus and the wall layers, longitudinal layer with the inner ring and outer longitudinal part of the muscle proper layer, and you can see all that structures highly sensitive in real time. So we have not only to inject into vessels, arterial vessel, venous vessels, but we can also inject or ingest into the esophagus, anus, and cavities. And this is really a promising and very exciting future of contrast-enhanced agents and their applications. Here you can see diverticulum at the esophagus. It's called Zenker's diverticulum, and my friend SHANG has been publishing about that. It's retaining contrast over time. So it's not going like we have seen in this video. It retained in the diverticulum, and we can, without any radiation exposure, diagnose also extravascular intracavitary contrast-enhanced applications. That was erased through some aspects, tips and tricks of contrast-enhanced ultrasound. It provides general advice on the use of contrast agents for clinical decision making in the liver. And I review technical parameters, best B-mode imaging, best Doppler imaging as the prerequisites for a good contrast-enhanced ultrasound. The dual blood supply in the portal venous phase, a lying detector, benign lesions are iso or hyper-enhancing. NEV and malignant lesions show hypo-enhancement and wash out. Some inflammatory focal liver lesions might also show some hypo-enhancement and wash out, and we have to prove by biopsy and histological evaluation if that is for individual use of the respective patients. So thank you so much for listening, and hopefully to see you next time in beautiful China, in Shanghai. I'm very much looking forward for a personal meeting, but I enjoyed very much also to lecture in front of you from nice Switzerland. Thank you so much.